Hotbed Talk,
where we've got Denny Levett. She's a Professor of Perioperative Medicine and Critical Care at Southampton University and the lead for perioperative care there. And she's going to talk to us today about prehabilitation. So, Denny.
Thanks for that kind introduction, Jim. So, as Jim alluded to, I am a perioperative physician, and I also lead our elective post-op critical care unit. So, as such, I see major surgical patients both before and after their operations. And fortunately, I'm also an optimist, and I see the perioperative period, consequently, as a window of opportunity. It's a window when we have the opportunity to affect our patients' behaviours at a time when they may be particularly receptive to medical advice, because they are facing, in the very near future, a potentially lifestyle-threatening event, or even a life-threatening event in the form of their major surgery. And I think, as a group of clinicians, we have a duty of care to our patients at this point to address their lifestyle behaviours, certainly the ones that may affect their short-term perioperative outcomes, but I feel we should also be ambitious about their longer-term health outcomes. But it's because it is really very clear that the behaviours that affect their short-term hospital outcomes may also affect their long-term health outcomes more generally. And if we can affect potentially long-term behavioural change in this period, we may improve their long-term outcomes. And perioperative medicine, as you all know, is about the patient-centred integrated care of the patient from the point of contemplation of surgery until full recovery. And so it's a really long time period, and the time when the patient's in theatre is actually a relatively small window of that journey. And I think we need to bear that in mind. And if it was your mother or a colleague, or indeed yourself, that was about to embark on a surgical journey, I think as a partner in your own care, you would expect, first of all, to be involved in the decision-making about whether or not you're going to have this surgery and what the benefits for you personally are going to be. But having made that decision, you would also expect that you're in the best possible state to withstand that operation, and that you're cared for in the best possible way whilst in hospital, and hope to be harmed in as little a way as possible, and indeed that you would recover as quickly as possible, at least back to your baseline state. And in the case of quality of life improving operations that we heard about earlier, such as hip or knee replacement, you're hoping that your long-term quality of life is going to be better. So that leads me to the concept of prehabilitation. What do we mean by prehabilitation? You can see the definition here. It's about enhancing the patient's functional reserve ahead of the operation. We have a unique opportunity in the time between diagnosis and the operation itself to intervene and to improve the patient's resilience. So if you think about the perioperative period, a patient has a baseline status of functional capacity, and we would hope that they are independent at the beginning of the surgical journey. And then the operation happens, and there's an acute fall in functional capacity, which is a normal part of the perioperative process. The duration and the depth of that fall will depend on the severity of the surgical insult, and indeed the rate of recovery depends on your baseline function. And what you'll find is that the majority of patients go back after a period of less than normal function, we hope, to their baseline. But there are some unfortunate individuals down here in the dotted line who never actually recover their baseline function. And for those patients, elective surgery has turned out to be a catastrophe, really, particularly if they do, as is the case with this patient here, fall below the line of functional independence. So you come into hospital functioning on your own at home, and you leave hospital and have to move into institutional care. And I would suspect that most patients have asked that is an outcome they really want to avoid, and many patients in surveys have suggested that's an outcome worse than death. And I think we need to be very careful to ask our patients what outcomes are important to them. So as Monty suggested this morning, it's not what's wrong, it's what you want, and what are you expecting to achieve with this operation. So what are we hoping to do with prehab? We're hoping that by intervening before the operation, we can improve the functional state at baseline, and so you get a faster functional recovery. And for those individuals who have a complicated recovery, which we may not in all cases be able to avoid, what you find is they still stay above this line of dependency, we hope. And so by improving both the rate of recovery and the recovery level to which they return, we hope that we will reduce their complications, their hospital length of stay, and consequently the health costs of this episode of care, and importantly, the health-related quality of life for the patient in the longer term. So, it sounds like a great idea. Why aren't we all doing it? Prehabilitation obviously makes intuitive sense. It clearly can't be a bad idea to improve someone's functional capacity. And I would suggest this slide, you can't read the detail and you don't really need to. It describes, it's one of the King's Fund's slides describing the surgical journey. And I think all you need to say, having looked at that, is the perioperative journey is incredibly complex and there are huge numbers of stakeholders. And it will be different in different regions, and in different countries indeed, and the challenges will not be the same everywhere. And to me, having led a perioperative medicine service for the last few years in Southampton, the biggest challenge I often face is how we get access to the patients early enough in the surgical journey. People always want to ask me what sort of exercise training we use, and I would say it's sort of irrelevant if you don't get to the patient in time. So the first thing you need to do is go and map your pathways. Because I think one of the problems is that the perioperative traditional pathway does not help us in terms of getting to patients and prehabilitating them before surgery. So the patient sees their general practitioner, they come up to the hospital secondary care environment, we make a decision that they're going to have an operation, and then finally they come to an anaesthetic pre-assessment clinic, which I'm never sure is a very good name, because in our institution sometimes it happens 2 days before surgery, if you're lucky a week, and maybe 2 weeks, at which point you have a week or so to try and address all of these comorbidities we've been talking about in our increasingly frail patient population. So comorbidities, poor behaviour, smoking, drinking, etc., etc. And that's clearly insufficient time. And this is another way of looking at just at the pathway once a patient's got to hospital. So if you take, for example, an esophageal cancer patient who presents to their GP with dysphagia, they either come and see a surgeon or they go directly to an endoscopy. If we are honest, the point at which we first contemplate surgery is when we look down and see an obvious craggy tumour with the camera on the end of the endoscope. And we know at that point in time, if the patient's staging is not too advanced, the greatest likelihood of a cure for that patient will be a major operation. But what happens next? Actually, we do an awful lot of investigations to stage the tumour. This takes several weeks coming back and forth, and then the patient is discussed at an MDT. I also like that term, multidisciplinary team. Actually involves a surgeon, a radiologist, and a pathologist. In most centres, there are no perioperative physicians, and actually nobody tends to discuss the patient that is attached to the tumour that is operable or inoperable. And then from there, they go to have neoadjuvant chemoradiotherapy, which is currently the standard of care before esophagectomy for major surgery. And then finally, and the chemoradiotherapy takes 9 weeks, and they have up to 9 weeks to recover after that before they move to surgery. So 15 weeks from the MDT until they get to surgery, but we see them the week before. Whereupon we discover they are smoking, drinking excessively, they're malnourished because they haven't been able to swallow and their appetite's been poor for the last few weeks. They've got poorly controlled heart failure, diabetes, etc., etc. And then the surgeon says, well, we haven't got time because we've got the operation in 2 weeks. And we're up to the 62-day waiting target. There's not enough time. And I would always say to the person that says to me, there's only 2 weeks. That's always complete nonsense. If you go back to the original referral of the patient, you will find that we've actually known about them for at least a month, and they've been having CTs and other things. And what we as perioperative physicians need to do is to get to those patients earlier in the decision-making. Because one of the other things to say is this, if this is the first time you start discussing surgical risk, it's way too late in the pathway. The patient has been preparing for an operation for nearly 4 months by that point in time. You know, trying to persuade them the week before the said operation that perhaps in their case, it might be a too high-risk affair and the benefits may not be outweighed by the risks or the functional harm is very difficult. You know, if we are going to be truly perioperative physicians, we need to get involved before the decision is made and contribute to the decision that's made for surgery. So then you present to the patient the best treatment plan for them, not you need an operation and we're now going to get you to jump over a number of hoops to see if you're fit enough for it. Because that's actually back to front. It's just the way we've always done things. And I'll talk more about this when I talk about the Perioperative Medicine Service in Southampton, but one of the things we need to do is to redesign those pathways, as I said, to try and get earlier access to the patient, and we talk about staging the patient at the same time that we stage the patient's disease. And so then, if you manage to do that, suddenly there's a huge opportunity when we can improve the patient's health outcomes. You have up to 18 weeks for an esophagectomy. And in many elective surgeries, such as hip or knee replacement, you have a long period the patient's on a waiting list to intervene. And the other important thing about this slide is engagement of the primary care physicians in this role, because we need to work in a multidisciplinary way. This will not work if we're just working alone as a single specialty in hospital. A lot of perioperative medicine is about communication, both with the primary care team and with other specialists within your institution. So what sort of targets are we aiming for when we're talking about prehabilitation? So I've artificially really divided these up into problems that relate to behaviour and others that relate to comorbidity management. I haven't got enough time in 20 minutes clearly to cover all of these. I'll talk a little bit more about comorbidities tomorrow when we're talking about perioperative medicine in Southampton, but I'm going to focus on the behaviour change literature in the next 10 or 15 minutes. So I think it's really important when we start to thinking about behavioural change that we realise that other clinicians have been trying to change behaviour for a very long time, and actually ignoring their literature database will be to our detriment. We all know that exercise is good for one, but a lot of us don't do it. And one of the problems with behavioural change is that it's not easy. But if you speak to psychologists, they think we have a great advantage as perioperative physicians because we have an impending goal. Because one of the problems is with a patient or an individual trying to tell them that giving up smoking now will prevent them getting a stroke in 20 years' time. It's not an immediate response to that behaviour change. And so it's harder for the patient to maintain the enthusiasm for changing a behaviour that they either enjoy or may be addicted to. So we have this impending event, the surgery, and that gives us extra power in terms of motivating patients to change their behaviour. And I don't need to go over all the detail here. We all know that smoking is bad for you. We know that it's particularly bad for you in the perioperative period. Your surgical outcomes will be worse in terms of complications, length of stay, mortality, and cost to the healthcare system. And so clearly you should give up smoking, not just for your short-term surgical outcomes, but we know about the long-term risks of cardiovascular disease and cancer as well. I think we often feel that patients have fatigue of being told to give up smoking. We think they must have been told 100 times before they get to us. But actually, if you go to the public health literature, it's quite clear that every time a doctor mentions giving up smoking, as Natasha alluded to, this effect of us as doctors is actually stronger than hearing it from the TV or from a relative. A proportion of people will give up. And so we should mention it to patients every time we see them, even if it has been mentioned 30 times before. We should ask all patients about their smoking behaviour. We should advise them to quit. We should tell them that they're much more likely to quit if they engage in a quitting programme. There's very good evidence to support that. The quit rates are more than tripled if you are actually in a behavioural modification with access to drugs for nicotine withdrawal. And so we need to act. And this is another important point for prehabilitation. We don't need to have a new smoking cessation service. We can find out what smoking cessation service is already available in your community and signpost the patients appropriately. We don't need to reinvent new services just for surgical patients. Alcohol cessation, there's less good data about the outcome perioperatively for problem drinking, but we know it has long-term harm. This is the Audit C questionnaire, which is one of those most commonly used to screen for bad or abnormal drinking behaviour in the preoperative period, and we should signpost these patients to alcohol cessation teams, again, which should be available in the community. What about exercise training? We all know that physical activity is good for you. You may or may not know. If you know me well, you probably do know, because I do talk about it a lot, but there is currently a physical inactivity epidemic worldwide. 3.5 million people are dying every year from lack of physical activity. In the UK, in the last large survey of physical activity, 40% of 40 to 60-year-olds said they hadn't done a 10-minute walk in the last 6 weeks. So this is reaching unbelievable proportions, and it has massive long-term health effects. And we know from the perioperative literature that fitter patients have a better surgical outcome, less likely to get complications, and less likely to die in the perioperative period. But important things when you're trying to persuade the patient to change their behaviour is to tell them about these other health effects. And I would suggest to you most patients don't know about the reduction in dementia risk with improved physical activity, and they definitely don't seem to know about the cancer risk, even when they're cancer patients who've just completed neoadjuvant chemoradiotherapy, which I find quite extraordinary. And the Australian guidelines now state that exercise is an adjuvant therapy for all cancer treatment. So, is there any evidence to suggest that exercise training in the preoperative period improves outcome? Yes, there is. There's beginnings of data that we can definitely improve patient fitness, and the first data that suggests that has an important effect on short-term outcomes has been published in the last 2 years. And there are about 40, if you go to clinicaltrials.org, there are about 40 prehabilitation studies going on internationally currently in lots of patient groups, so I think more data will be forthcoming. This is some data from Southampton that was led by Prof. Sandy Jack and Mike Grocott, where we were exercise training rectal cancer patients. And you may know that during neoadjuvant chemoradiotherapy, your physical fitness decreases. So these patients, this was a prospective randomised controlled trial, they dropped on average by just under 1.5 mils per kilo. And associated with that, there was a reduction in their quality of life. And if they trained, this was a 9-week intervention program with 3 times a week in-hospital training of moderate intensity exercise. They improved by 3.3 mils per kilo. This is in their anaerobic threshold, whereas the patients in the control did not improve. You can see here that adherence was over 90%, so patients will participate in this. And the secondary outcome was health-related quality of life. And what we found was that patients reported that cancer treatments really do affect quality of life in a very impactful way, and that was improved by exercise. So they felt that taking control of their treatment, working in a group, improved their psychological well-being and reduced their anxiety, and they felt better prepared for surgery. In fact, the main complaint from these patients at the end of the study is that they wanted to come back post-operatively, and why weren't they allowed to come back to the laboratory? Unfortunately, we don't have that ability currently. So there's early suggestion that we can intervene to improve patient fitness. And studies in other patient groups show that the fastest change in fitness, this is just to summarise this, is in the least fit patients. They improve most quickly, and you can get clinically significant change within 2 weeks. So you don't need 9 weeks. You get continued improvement over time, but you can get important change within 2 weeks. So the next thing I want to talk to you about, and I think most of us in the room might feel a bit uncomfortable when we start thinking about preoperative nutrition. We may know that very malnourished patients are picked up by a dietitian team, but I know that in our institution we do not routinely prospectively screen all major surgical patients. And this is some data published by the Perioperative Quality Improvement Group just earlier this year, and they were looking at the fact, so malnourished patients have 3-fold increased risk of morbidity and 5-fold increased risk of mortality. That's a really big change. We give drugs for medical conditions which have a much smaller treatment effect than that. So 3-fold increased risk, but yet only 1 in 5 hospitals actually screens for preoperative malnutrition. 75% of surgeons think it's a good idea to do something about it. We know that for every dollar you spend on a nutritional supplement, you save $52 in hospital costs. This is data from the States. But yet only 20% of patients actually ever receive any preoperative nutritional supplementation. And 2 out of 3 patients presenting from major abdominal surgery are malnourished at presentation. So there's a lot of things that have less impact on our patients' outcome that we spend a lot of time attending to, and we spend very little time attending to this. And I think one of the problems is, as physicians, we learn very little about nutrition during medical school and during our training. It seems to be the domain of dietitians, and assessing malnutrition is not part of our normal clinical life, and perhaps that needs to change. So the same paper suggested, first of all, the first step to improve this situation is to do some nutritional screening routinely as part of practice, so we can see how big the problem is and then affect change as required. And this is a perioperative nutrition score. You can see here If you flag up on this score, then you should be referred to a dietitian for a full nutritional assessment and intervention as required. And these are the POCI Nutrition 6, the principles of looking after nutrition perioperatively. We must screen. Probably protein intake is more important than calorie intake in the immediate preoperative or perioperative period. You should fast for as short a period as possible, and you should consider oral nutritional supplementation in all patients. And finally, nutrition is a team management game, and so we do need input from our allied health professionals. Psychological factors are also important in surgical outcome, and Natasha alluded to this. She talked about the effects of anxiety and depression and pain, but many of you may be unaware that anxiety and depression also predict post-operative complications. Now, the biology of this is poorly understood, and it may be that anxiety and depression affect behaviour, and behaviour, i.e. not getting out of bed and not mobilising, affects those physiological complications. But there's very good association data that suggests that both are important. They affect pain as well. And there's also quite a lot of themes in the literature suggesting that these two features of individuals, namely their self-efficacy, which is defined there, and their resilience, have important effects on pain, complications, and quality of life post-operatively. And the really important thing about all of these factors is that they are amenable to treatment. Cognitive behavioural therapy or motivational interview techniques can affect your self-efficacy. And this is a patient's belief that they can actually manage their problems themselves. And resilience is basically the ability to cope with an insult, such as an operation. And mindfulness and motivational interview have been shown to improve these two facets of personality, and perhaps we should focus on this a little bit more. This has led to the development of multimodal prehab programs, which look at, in some cases, nutrition and or psychology and or exercise. So this is a study that was published last year from Barcelona, where they looked at a high-risk cohort, so ASA 3 or above, or a functional score suggesting they were very functionally impaired, and it was a randomised prospective trial. They were randomised to an exercise intervention and motivational interview techniques, and they reduced post-operative complications by 50%, which is the first hard clinical outcome showing efficacy of a exercise intervention preoperatively. There's been interest from Montreal and Franco Carli's group in trimodal prehabilitation programs looking at psychology, nutrition and exercise, and it is quite clear that malnourished patients don't respond well to exercise. So you need to ensure that the patient is nourished before you start trying to do an exercise intervention. And the early data suggests this is feasible, that patients will comply, and there has been improved functional recovery in the trimodal. And subsequently, in bimodal nutrition and exercise studies, a recent meta-analysis suggests that there is evidence of reduced length of stay and hospital costs associated with these programs. And so this has led, in the UK certainly, and in our area, to the STP becoming interested in integrated plans to introduce prehabilitation into the pathway. The Westbit study is led by Professor Sandy Jack in Southampton and Mike Grocott, and this is a prospective, pragmatic trial looking at a prehab program that involves a psychological intervention, which is motivational interviewing and these behavioural change techniques I alluded to in one arm, an exercise alone in another arm, and the combined arm. And we're looking at in-hospital length of stay as a primary outcome. This started recruiting in November last year. It's community-based exercise training across the entire of the Wessex region, and we hope to recruit 1,500 patients in the next year. It's also led to the uptake across the UK of these Fit for Surgery schools, which are behavioural interventions. I'll talk a little bit more about the Southampton Fit for Surgery school tomorrow, where we address nutrition, smoking, drinking, exercise, and weight. And so finally, the last thing to say is that we really should learn from our colleagues, and when we introduce these prehab programs, we need to take advice from the behavioural change science. Goal setting is important. Diary monitoring improves compliance by 50%. You need to think about these techniques that affect self-efficacy. And by doing that, there is hope for prehabilitation in the future. You need to map your pathways. You need early access to the patient, and the care needs to be truly multidisciplinary. and involve behavioural science in the team. Many thanks.
Lee Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.